TopMedTalk.
Hello, welcome to TopMedTalk. I'm Andy Cumpstey, and I'm here again at the evidence-based Perioperative Medicine World Congress here at London in the United Kingdom. It's day 2 of what's been a really fantastic meeting so far. We've got guests and speakers from all around the world, and that leads us into very nicely our international panel we've got joining us this morning. Thank you all for joining us, straight after a really interesting session on perioperative medicine. So I'm going to ask you all to introduce yourselves in a second, but we've got Selwyn from the United Kingdom, Vanessa Beavis from New Zealand, and Maxime Cannesson from the United States. So Dave, maybe if you could tell us a little bit about your current roles and what you're doing at the moment.
I'm talking here today as the Director for the Centre for Perioperative Care. I have a background clinical role in anaesthesia, critical care, and perioperative medicine, and I'm the Acting Chief Executive of a large deviation and a called Sherwood Forest Hospitals.
Fantastic, thank you. Vanessa, same question to yourself.
Well, thanks. I'm Vanessa Beavis. I'm a former President of ANZCA, and I'm now Director of Professional Affairs for ANZCA, and I've had a long involvement with medicine right from the very start.
Yeah, brilliant, thank you. And Maxime.
Hi, good morning. So I'm Maxime Cannesson. I'm here as the chair of the Center for Perioperative Medicine with the American Society of Anesthesiology.
Fantastic. Well, first of all, thank you all very much for giving up your morning break to come and join us here on TopMedTalks after a fascinating session. It was really great to hear from all three of you. There's so many things we could talk about that you all covered, but I wanted to dive in straight away. One of the common themes that you all touched on in your talks about this diversity element and the importance of diversity of specialty, diversity of profession, diversity of thought, as you called it, Dave. You all touched on it, but what do we think about that as a founding framework of the life of perioperative medicine, though? Why is that important?
So the Centre for Perioperative Care, or CPOC, is hosted and largely funded at the Royal College of Anaesthetists, and we've been in existence for about 6.5 years or so. And in essence, we had to get a professional body to grab perioperative care, or perioperative medicine as it was said in those days, but perioperative care, and start to drive that agenda forward. As part of that, we recognised right at the start that opening it up across different professional stakeholder groups and different specialties, it would be of benefit there, helping us to deliver the aims that we felt were needed. At the same time, we were very keen to also put the patient at the centre of our thought processes and put the patient's voice down. So we've got a very strong patient representative group as part of the board. So we've got 11 what I call high-value professional stakeholders made up of Royal Colleges or professional organisations, but it's not just Royal Colleges such as the Royal College of Surgeons of England or the Royal College of Surgeons of Edinburgh. It's also the Royal College of Physicians, the Royal College of Nursing, the Association for Perioperative Practice, the College of ODPs. So it cuts across not just the specialty base, but also it cuts across the professional workforce base. And as you say, my take on this is it's that aspect that gives us real strength because it adds to that diversity of opinion, diversity of approach, and diversity of thought, which ensures that actually we do capture the actions and perhaps the progress that we need to make from a different view or different views.
And how are those views reflected in New Zealand, Vanessa? Does that hold true in your part of the world as well?
To a large degree. In New Zealand and Australia, we have started with perioperative medicine to try and get the medical specialties together, because that's where it all starts and you can cooperate at any level. So we thought, okay, well, which medical specialties then touch the entire pathway? If you take the care pathway, so from the moment that surgery is contemplated through until they get referred back to their primary referrer for ongoing care. And so that was GPs on both sides of the Tasman, so the New Zealand ones and the Australian ones, as well as the rural and remote GPs. That's at each end. And then during the rest of it, the physicians, in particular geriatricians, they are a key group for us, but all internal medicine physicians, the surgeons, anaesthetists, and intensive care doctors. So all of those people who will have something to do with it. And as I said in the talk, it's very clear that no one particular group has the full skill set to deal with all the multitude of problems that you might have with a comorbid or a patient who's deserving of perioperative input, rather than just a simple problem in-out kind of thing. But no one has the full skill set. We can't do it on our own because we're in the traditional anaesthetic way. We're just there for a very, very short time and we'll end up trying to fix problems all over the place. You really do need everybody. And the only way to do it is get everybody involved right early on. Because if you try and just add them in afterwards, why do they feel any ownership? Why do they feel that they're actually really part of it? So that's what we have tried to do. And I think it's taken a long time because it takes time to build up that trust. Yeah,
And-
so that people work together. Yeah.
I mean, I think Dave touched on it very nicely, but getting that professional buy-in from the different organisations, different bodies,
Yeah.
that's, I guess, our UK approach. You've sort of taken another step further, but on a different angle and looked at the chapter Perioperative Medicine. So maybe you can tell us a bit more about that as well.
It's not a model that we're familiar with really in anaesthesia, for example. So we decided that anaesthetists probably could provide the home for the community of practice called perioperative medicine. And so we put a significant amount of resource into it and infrastructure to try and make that happen. Because if you're trying to run it with a committee, it's very vulnerable to somebody's saving money or something. So a chapter is not a faculty. Physicians have chapters as well, the geriatricians and the internal medicine for a subspecialty group. But we thought that a chapter would be a good way of providing that home for the community of practice and to be the center for the academic and research endeavor, as it were, to provide the science that backs up the whole care pathway that everybody does. So that's what we decided to do with that. It's an intermediate step between a faculty, but at the same time, it's much stronger than just a committee, and it reports directly to ANZCA Council. And perioperative medicine per se is a key strategic fence post, if you like, for ANZCA. So that's why we've gone that way.
And what about in the US, Maxime? I mean, again, we talked about the diversity, but how does CPMed organise that diversity and how does that impact on practice?
The US and the Center for Perioperative Medicine, we know for sure is that this, what you call the diversity, this multidisciplinary collaboration, we understand that's the foundation that's going to make perioperative medicine a success or not, right? If you don't have it, that's not going to work. And actually in the US, we've learned it the hard way several years ago. And so there's no doubt in our mind that this is what we need to build. Now, that's why I'm personally so grateful to be here with people from, the UK, Australia, New Zealand, because we need to learn how others have done and have been successful at doing it. If I have to be very honest, we are trying in the US with the CPMed to build these blocks toward this multidisciplinary collaboration. I think the first step was to get together with the anesthesiologists to make sure that, at least in the anesthesiology community within the US and elsewhere, we're on the same page, that we have the same messaging, we share the same goals, the same values, the same approaches. Because again, in the past, we've realized that there is a lot of different societies working on this within the US, and that's not going to help if we don't have the same voice to include other stakeholders outside of our specialty. So the first stage was everybody's on board. Now, next year, we'll have a meeting with other stakeholders, with the surgical professional societies, internal medicine. But that's why, again, we need to learn from others because it's a landscape that's not easy to navigate because, as you said, it's based on trust. And you said it earlier today at the meeting, trust is something that you build over years and that you destroy within a few seconds. And we've been here before. We have to start again from scratch and we don't want to make this mistake. So we want to acknowledge we made these mistakes in the past. We had some failure. That doesn't mean we're not committed. We want to keep on going and learn from this.
I think also it's a sort of, not all anaesthetists thought it was a great idea. So you have to start with your own internal people first to try and explain what it is, get the trust. No, this isn't taking away from you as an anaesthetist. It's just extending your role back into where you can provide value. So you start with them and then but then you have to get other people on board. And when they're all in the same room, you have to be prepared to make changes because if there's something that they all hate and you don't really see the point, you have to be responsive. Otherwise, it's just a tick box exercise.
Yeah.
We'll know what consultation's like.
So I was going to say, I absolutely agree with that. And, clear, compelling vision and then the ability to tell that story. But actually, if you've got multiple stakeholders, multiple professions, multiple specialties, and actually using them as the vehicles to get that message into their own professional groups is how you win the battle and is absolutely key to this. And of course, they help co-design something that's even better. So you might have a vision and an idea that actually is fundamentally flawed and that gets altered by a different professional opinion. So it's absolutely key.
I want to pick up on, again, your point about the holistic patient at the centre of all of this, which is fundamental to everything we do, but we probably don't emphasise that enough sometimes.
I think in healthcare, we've been really good at designing what we think is good for the patients. I might say outpatients is a perfect example. So any of you who've been through healthcare and you've been involved in outpatients, it's incredibly frustrating. You wait a period of time, you go and see a clinician, you get sent off some tests, you then have to come back again for the results, then you go away again, and then you come back for this sort of treatment plan. That's bonkers. And the value for the patient in all of that is minutes. and it takes days and weeks. And, not surprisingly, there's dramatic needs to change. And we can get so much better at this. And, I'm sure we'll talk about the 10-year plan for UK, 10-year healthcare plan, but there's a clear direction in that about actually changing that outpatients model. And obviously, many of us have started to introduce one-stop shops and those aspects, but actually there's something really fundamental we can do about what's the real value that patients are getting from that consultation. Why have we designed it all around the clinician sitting in a room because it's convenient, as opposed to the patient who has to travel often for hours, numerous buses, for example, for what?
And you touched very nicely on the 10-year health plan. And again, for you and I working in the United Kingdom, that's mainstream news almost every day at the moment with the government's new strategy. But for our international listeners, maybe can you fill them in on background to that and why it's come in and what the sort of direction of travel is looking for here in the UK?
Yeah, so in the UK, we had a change government just over a year ago, and the NHS, our healthcare service, is very politically charged and is key to the voters. And pretty soon the government came in and they did what they described as a diagnostic report undertaken by Lord Darcy, and they described the problems with the healthcare service, and they were many. And in reality, it's a service that was designed sort of 77 years ago, which was great, but actually healthcare has moved on and the patient need has moved on, as we've just been talking perhaps. So that was the diagnosis, if you like, of the problems with the healthcare in the UK. And then there was a need to actually, how we're going to fix this. So we're either going to not fix it or we're truly going to work together and fix it, and that's across health and government. And so this plan has just been released, setting out some really quite stretching ideas that need to be achieved over the next 10 years. It's described by the political owners as not just a plan for the NHS or the healthcare service, but a plan for health of the country. And much of this is founded on the belief that actually there needs to be a societal change in the messaging, and they describe it in terms of curing our sick society and really getting into that prevention side of things that we've talked about for years and years. So it has three main strands. It has a desire to move care closer to the home and to the patient, as we've talked about, perhaps in terms of there's more convenience, that's hospital to community. There's utilising technology to help us progress and become more efficient and become better at communicating. And then there's a component about actually having that mindset change from health becoming reactive and all about treatment to health being preventative. So actually thinking about secondary prevention and maybe even primary prevention, I suppose.
I mean, it's a meaty document, as you said in your talk, but I'm quite excited by the proposals, I've got to be honest.
Yeah, and I think many clinicians will say exactly that. It's exactly what we want.
Yeah.
We've been talking about this and we've been saying why not? The key to us will be the delivery. And to do that, we will have to hold our nerve. And one of the things we're not good at in the NHS is change. And this is all about change. And again, the politicians say that if we don't deliver on this, if we truly do not make this change, then the health service will fade away and become something else.
How much of that reflects on your own practice and how much of that is a UK only problem?
It's everybody's problem, I think. And we're still hoping that we get a 10-year plan, it's a cross-party agreement. Part of the thing with us is that our electoral cycle is every 3 years, so nobody's really got a chance to do anything. So it tends to be sort of things like a waiting list, because it looks good on the, on the front page of the newspaper, whatever it is. But you do need a long-term plan. And I do think, which is something that they are looking at, is primary care is essential to start strengthening and looking at properly. But also, as you say, it's not at all patient-centric. I mean, it's a nightmare when you have to get involved in that. Anyway.
You can't get to see the GP. You do this, they call it the 8 o'clock scramble, where you try and get an appointment or whatever. And we've fundamentally broken that, but actually we need to fix that because primary care or GPs, I hate the word primary care and secondary care because that creates artificial barriers. I want to get rid of primary care, secondary care, social care, just call it care. Because that's what the patient is.
Okay, that fits more with this plan moving into the community. Again, that's one of the strategies. Yeah,
exactly, around integrated care organisations, vertical integration, absolutely. And, I think, so if I take my patient or my chief executive hat on, it's exactly what I think will be the future of district general hospitals or hospitals. And this is exactly where we need to move towards.
And so again, I don't think it's a real change of topic, but just coming back to the patient-centred thing, I mean, patients want these three things. That's loud and clear from our interaction with all patients as well as healthcare providers. But they want that in safe healthcare environments. That's, again, you all touched on that really nicely in your talks. But patient safety is sort of first and foremost front of everything we do, isn't it? But I mean, Maxime, Vanessa, how does that play out in practice in the perioperative medicine context?
So on the patient-centered care, that actually, obviously, that should be at the core of anything we do in medicine, right? There's no question about it. That's very clear. Now, there is also something we need to be careful about, is that medicine is becoming, there is consumerization of medicine, right? It's becoming a consumer market where we, as patients, we are all patients in some way, shape, or form, we consume medicine. And to some extent, that can be also tricky to manage, because if you go too far in the concept of patient-centeredness, that's going to put a lot, the cost of medicine. It's really going to have a huge impact. So I just wanted to make this point because it's pretty important in this concept, and even perioperative medicine being patient-centered doesn't mean that we do not remain physician-centered in the expertise, the skills the physician bring in the decision making. And I think it's also very important today, even more than ever, to be physician-centered, because there is a huge level of burnout in physicians across the world. And if we do not reconcile the two, long-term, there's going to be an impact on patients. If physicians leave the workforce more and more, and then if they feel disengaged, that's going to be an issue. And we need to keep the physician also in the center in the decision-making. In the specific concept of perioperative medicine and being patient-centered, it's obvious that it's the key, and it goes back to the multidisciplinary collaboration. You want people to work together around the patient, as opposed to today, I think all the specialty, at least that's how it works in many places for us in the US. Not every place, but that's one of the big problems, that each and every specialty works in a silo. If you look at the hospital architecture, like the administrative architecture, it's also not helping, because I don't know how it is in Australia, New Zealand, or in the UK. You have hospitals administration are divided by departments, which by nature tend to make the specialty work in silo and outside and distant from the physician. So there is a push also associated with perioperative medicine in the US to move away from department structure administratively to what we call disease-based units, where groups of healthcare providers are going to be organized not around a specialty, but around specific disease. So, for example, musculoskeletal disease. And then in a musculoskeletal disease unit, you're going to have rheumatologists, orthopedic surgeons, you're going to have anesthesiologists, physical therapy nurses, all within the same department, and try to break the silos between specialty, which to me, it's also at the core, one of the reasons why we tend to not be patient-centered like we should be, and more specialty-centered.
That leads me to my next point, Vanessa. I was going to ask you about, you have a really nice slide up in your talk of the patient journey through the care. So for those that are at home listening to this and don't understand what I mean by the nephron side, maybe you could sort of summarize a bit better than I'm doing what I mean by that, but also how maybe that matches back to what Maxime's just been talking about.
Yes, it's really interesting because just reflecting on what you were saying, if you think about ERAS is a really great thing, but it focuses on a specific operation. The patient is going for their hip or their valve surgery or whatever it might be. Perioperative medicine, rather, I think, focuses on the patient. So you could say, okay, let's look at the respiratory side of things or their comorbidities, whatever. So there's a subset of perioperative medicine. It describes a pathway that goes up and down, and it's divided into 3 sections, but it's a continuous flow. And it starts with the GP or when the decision to surgery is contemplated, and then goes back to when the patient is back to their primary referrer. And there's decision points along all of those things. The 3 sections are pre-op, which is decision. So at that particular point in time, there's a decision point. Are we going to do this or not? And if not, they get referred back to the primary referrer and the whole pathway that then has to help patients through that particular part. If they're proceeding for surgery, then it's all about risk optimization. And that's the first bit. Then the next bit is, so that's the pre-op, and then the intra-op thing, which is providing the anesthetic care and the post-op disposition. And the last phase is when they're out of their intensive care or PACU or wherever, back into the ward, rehabilitation, and then finally discharged back into the community. So it tries to have an equal focus on all of those particular areas. And underneath it all, it is all about shared decision-making, because informed choice is one thing, or informed decision-making. That means we give you all the information and say, okay, now what? Well, most people can't deal with that. I mean, if you go to a lawyer, for example, you get all this and you have no idea. And then you have to say, well, you're the expert, you decide. But at the same time, unless somebody asks you the question, okay, well, what is it that you want? What are you expecting? What are you most worried about? you're not going to have any input into that. So you've got all the information you ever want, but it's not really shared decision making. And so a lot of MDTs, multidisciplinary team meetings, that's all about, okay, let's work out what we think is best for the patient and then give them all the options, sort of a thing.
And
Yeah.
you said pre-admission was the easy bit to solve. Now the bigger problem is the post-op area. And
Totally.
that feeds with your talk, Dave, about complex discharge rehabilitation. That's the bit we really haven't solved yet, isn't it? Post-operative care, post-operative management.
So I think Vanessa has nicely described some of the change that we're trying to do. Comes back to that patient-centered aspect in terms of we're trying to think about a pathway as opposed to a specialty.
Yeah.
And that's about removing those artificial barriers. So if I go to present myself to a GP and I don't go saying I've got respiratory disease, I go saying I'm short of breath. And that could be a whole host of things. A whole host of conditions, I think it's that. Or you go to the respiratory physician, I think it's that. Or the upper GI surgeon, because it's reflux. And it's none of those. Or it's a combination of all of those. And we wonder why we get ourselves into trouble. And patients then sort of fall between stools and get confused. And so this is about wrapping the appropriate care around the patient through that whole pathway, right from the start all the way through. And as you say, a key component of that is the shared decision making, but also the clinical decision making in terms of risk stratification, modified risk score, whatever your favorite modified risk score is, of greater than 5%, then if you send them back to the ward, they're going to come into trouble. It's about actually, have we got the care arranged? Have we thought about that? Thought about where they're going? And again, with the discharge process, in my hospital, I host a discharge hubs, and there's about 20 people in it. They're all talking to each other, and that's the complexity of discharge these days. We love this in healthcare, don't we? We overcomplicate the already complex, and we've got all those artificial barriers. But actually, as a clinician on the front line, and I'm trying to get a patient either into a rehab facility or some care support at home, then I haven't got a Scooby about how I go through all of that. So I need someone to tell me that. And that's really something, the newer resources we've developed for the teams at CPOC to help navigate through that.
Any follow-on?
Oh, no, I completely agree. It's like just earlier on in something you were saying, you said you go along to the GP and say you've got short of breath. The problem if you have, as a doctor, when you go and see the GP, you go along and tell them I've got heart failure. You tell them the diagnosis, and then, then they've got to try and, whereas a patient might go and say, I'm short of breath. So it's more difficult for the poor GP to try and sort us out than, perhaps in a normal patient. It's incredibly complex. And that's one of the things with our qualification that we really noticed is that people were very able to risk stratify because, there's a million tools, as you say. And we're very fortunate in New Zealand. We've got one that's specific for us based on the Ramani Singi sort stuff. Because cultural ethnicity is a huge influence on how well you're going to do. And then there's, all sorts of expertise applied at the surgical procedure kind of level. But then afterwards, okay, now what? Even ICU, fabulous. Okay, but now how do we discharge the patient? What does the GP need to know? How do we get them to do it? And that in the qualification, that's the area, in fact, that people are struggling with. It's not just them. Others are struggling too. So it's hard to get it right.
Yeah, I think one of the advantages about doing care is it's about being a good communicator, but it's also about knowing who to ask to get that expert advice and recognizing that you don't have to know all the answers and you can bring the appropriate people in to help you with those conundrums that you don't quite understand.
So fantastic discussion, fantastic thoughts. To finish, where are we going with this? In the UK, in New Zealand, in the US, what are the challenges on the horizon and what should we be watching closely over the short future?
So I think in the UK, I think it's all about that 10-year plan, because what we have to do as a profession, in a specialty or a group of interested providers, is that we have to get behind this plan and we have to change how we provide that care. So we've got to think about in perioperative care and in CPOC how we can align with that triple shift. So there's someone who works on the front line, which pre-op screening tool do I buy? There's a multitude of them out there, but which one's the best? Or which intraoperative fluid monitor do I buy? Now, as professional bodies, it's hard for us to get behind particular companies and those sort of aspects, and we'll all have our favorites. But we can start that conversation and have that detailed review of what there is out there. And it'll be horses for courses. We've got to get behind the shared record and recognise actually it's important what we write in the medical notes because the patient will be seeing it That's all about communication and language. And there's the whole host of interoperability to that. So we can do all that. That prevention side rather than treatment is music to our ears. And, the statistic I gave in the talk is that every single anaesthetist who goes and sees a patient says, "Do you smoke?" And the patient goes, "Yes." And it's, "So what?" What do you do then? You just put it on your form or tick. Actually, 4% nationally in the UK, 4% of patients who smoke get referred to a stop smoking. We know that 56% want to give up smoking. And why aren't we doing that? And we've got good examples of putting people into relatively short help groups to stop smoking. And actually, the surgical stimulus is so powerful, it stops some smoking. We've done a lot of work in my organisation around our maternity. We've got a very high instance of smoking mothers, and giving them a carbon monoxide monitor so they can see what they're breathing out has dramatically changed. And we've had nearly 200 and something smoke-free babies now. Of course, that stops not just babies being harmed, it stops the mother, the partner. Yeah. So it's a triple whammy. And so simple, just thinking differently, simple tools to do that. But that prevention in general, we really have to all own it. We've got to stop everyone talking about it, a bit like climate change, stop talking about it, actually get on and do something about it. And then the final thing is, and this is the challenging one for us, we all work in big hospitals, we've got shiny lights and a kit, and we love it, but actually we've got to put things out in the community. So why aren't we doing all our pre-op screening out in the community? Why aren't we using some of these digital tools to make sure people don't need to come in to us? What are we thinking about what operations we're doing in our hospitals and what we could possibly be doing out in the community? So those are the challenges for us in the UK. Think differently. We've got to really embrace this.
Well, I think we've probably all got similar problems. At least you've got a 10-year strategy now. I think for us, we have to get everybody's head out of the reads and out of the, how many hips have we done this week? How many cabbages or whatever it is, to look at the whole pathway and realize that there is opportunity and it's a win-up for the patients who then either the right operation instead of the big operation or no operation, or it's all congruent. So we need to look at the whole big picture rather than just the immediate thing that's underneath us at that particular point in time. And so for that, you really need the general practitioners because they are the sort of glue that hold the whole thing together and keep the keeper of the record and help the patient actually. But they can go to their GP who they've got a good relationship with and build that trust. As you said, teachable moments are really important. So I think that's going to be our thing. And then the other thing is all of this, it's not a substitution. This is going to be extra resource required. I think we should look around and see what opportunities have we got already where we could do it. So if I'm just thinking off the top of my head, they'll probably hate me, but the pain service, the acute pain service, for example, they go around and they see everybody who's got blocks and sick and, big surgery and all the rest of it. And I wonder if they could do just a little bit more and look at not just the pain, but also the other stuff in that post-op period. Certainly the nursing staff love it when the pain service come around because they've got, a specialist doctor or specialist nurse practitioner or something, and they get really good advice, at that particular point of time. And if they can sort of shoehorn it into acute pain problem, they will. Look at what there is. There must be some opportunity to do a little bit more with existing resource that you don't have to do anything else with, and to perhaps stop doing some of the stuff that we are unnecessarily doing.
Yeah, for us in the US, first we acknowledge it's going to be a journey to get there. It's going to take time. It's not going to happen overnight. And so what we need to do is to create a system that's going to provide access to care for these patients. And when they access the care they deserve, they need to have the best care and the best outcome associated with this care. So that's where perioperative medicine plays a role in the outcome, but also in the access to care, because when you decrease length of stay, if you're able to send patient home right after the surgery, turning what used to be an inpatient surgery into an outpatient surgery, you increase access to care every time you do that. So perioperative medicine is going to play a role in these two parts of what is the need of the American population when it comes to healthcare. Over the past 15 years, we've had access to electronic medical records. So we're already at a place where we can start implementing AI solutions, and that has an impact on perioperative care, especially the pre-op. It's also going to release some of the workforce, to be honest, from doing this work, which is today, when we were on paper, that required a lot of people to review charts. When we moved to digital, we needed less people to do that. With AI, it's going to be even less. That doesn't mean that it's going to take away jobs, but that means that we're going to be able to redeploy the workforce to other places where we bring more value. And I think one of the bigger strategies is going to be looking at where we deliver value care. And where we deliver value care means where do we deliver care that improves the outcome. But it doesn't mean it's value, it's not going to be a financial value. We do have anesthesiologists who are involved in care where they bring some financial value. For example, in GI, you could argue we help GI physicians do more cases to some extent and generate more revenue, increase access, but the actual medical value that we bring, is it really here or not? When you don't have enough resources, at some point you really need to question where are we bringing value? And so that's going to be a big part also of the work done by perioperative medicine.
Fantastic. Well, 3 excellent points to finish a really fantastic discussion on. Thank you all very much for your time. Thank you for all you've done and continue to do both for our specialty and most importantly for our patients. Thank you for joining us here on TopMedTalk. As always, you can find this podcast and all our other podcasts online on our website, on your podcaster of choice, on social media. We're on LinkedIn, Blue Sky, Facebook, Instagram, YouTube. Hit like, give us a subscribe. That really, really helps. And we need to say a huge thank you to our sponsors as well. So for this year, that's BD and GE, without whom we couldn't keep bringing TopMedTalk free and open access around the world. Thank you very much.
Thank you.
Thank you.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.